So let's wait a few minutes.
How many people are right now?
Right now, 33, 39.
39 and counting.
Rising.
40.
Yes.
Okay.
So we wait a few minutes and they'll all be here. And as always, we have people that will be like 5 or 10 minutes late. Brazilian time.
João, the audience is from all over Brazil?
Yes.
Or most from
all over Brazil.
All over
Most
Brazil.
Brazilian, but all over Brazil. I'm gonna grab some water and I'll be back in less than a minute.
Okay. So, Mike, the ASBMR meeting will be online this year?
Well, it's supposed to be in person, but it was moved. It was moved from Toronto to somewhere in the US. I'm not sure where.
Really?
And
I don't know that.
they're saying that it's going to be in person, but I'm not sure how many people will come.
Yeah.
Yeah, I think it'll have to be some kind of hybrid meeting where, you know,
Yeah,
there'll be an
most
option to
yeah.
sign on virtually.
Yeah, especially from people from Brazil, because they have to do quarantine in Mexico.
Yeah.
I'm looking here at the ASBMR calendar. It's to be announced. Next year is in Austin.
Well, you know, the Endocrine Society had a pretty big virtual meeting, so
Yes, yeah.
that seemed to work okay.
We have like 60 people. Let's wait another 2 minutes and we might start. Então, de novo, o Juliano fala, eu falo, Newton fala, e o Franzé fala, apresenta o Michael Wick.
So Joao, how is Isabel?
She's doing okay. She's working 100% home-based. She's at home. It's actually she's enjoying. She's working harder now than before. You know, with web meetings, she has 100 web meetings every day, and
Yeah.
it's a thing that's non-stop. Before she had 9 to 5. Now she doesn't have a 9 to 5 anymore.
Yeah.
And how is Maura?
She's good. She's doing a lot of babysitting for our grandson, who's
Okay.
here in town. So she likes
That's not bad.
that.
Yeah.
And she's helping immigrants to the U.S. Pass their citizenship exam. So she spends a lot of time doing that.
Okay. Oh, that's interesting. That's interesting.
And we're playing something called pickleball. It's a new family sport. Have you heard of pickleball?
No, never heard it.
It's
What is
played
that?
it's played on a court that's about half the size of a tennis court, and you have little paddles and you hit a plastic ball across.
Okay.
So it's very popular in the U.S. right now. It's a sport for baby boomers who have bad knees and shoulders and can't play tennis anymore.
Like ourselves.
Like me.
I'm gonna look at that. Juliana, I think we might start.
Então vamos lá. Queria dar boas-vindas aos palestrantes e aos participantes de mais um evento acadêmico aqui da SBEM Regional DF. Queria passar algumas informações de cunho prático, tá? Primeiro é que haverá tradução simultânea aqui. É só acessar o ícone que consta aí na barra inferior no canto direito, que se assemelha aí a um globo terrestre. E ali vai ter 3 opções: o canal em inglês, o canal em português, para quem deseja ouvir a palestra em português, traduzida, e o canal desligado, onde você escuta o som original, que obviamente vai ser em inglês. As perguntas serão respondidas ao final da aula e devem ser feitas por escrito no ícone também constante aí na barra inferior, que tem o Question and Answers, o Q&A. Tá? Passar a palavra aqui para o Dr. João, para ele fazer a abertura, a apresentação dos palestrantes, e iniciaremos logo em seguida.
Boa noite a todos. Fico muito feliz com a presença de todos aqui. Hoje nós batemos, nosso recorde de inscrição anterior era de 425 pessoas, hoje nós estamos com 500 inscritos. Temos que agradecer muito aos nossos colaboradores, Laboratório SEIB e Amgen, e o nosso patrocinador exclusivo, o Laboratório Axé, por nos ajudar a divulgar esse meeting. Nós temos aqui conosco o Dr. Michael Wick, que é um grande amigo das pessoas do metabolismo ósseo no Brasil. Ele teve em Brasília em 2019, aqui no evento da SBEM-DF, e falou à distância no Congresso de Odontologia o ano passado. Eu não vou ler aqui o currículo dele, porque ficaria meia hora aqui. Então, ele está sempre disposto a nos ajudar a falar, e ele fez uma aula no passado sobre imunidade e vitamina D, que foi um sucesso, e hoje nós estamos atualizando essa aula de uma maneira geral, não só a COVID e autoimunidade. E eu tenho aqui para coordenar essa sessão, Dr. Newton Dornelas, que vocês todos aqui, pelo menos de Brasília, conhecem. Ele foi presidente da SBEM-DF N vezes, presidiu o SBEM o ano passado com grande galardia, de um improviso grande por causa da pandemia. Hoje ele é diretor da Nacional da SBEM. E o Dr. Francisco José, que é professor da Universidade da USP de Ribeirão Preto e atual presidente da Abraço. Então, eu passo a palavra para o Dr. Newton Dornelas.
Boa noite a todos, boa noite, João, Dr. Mike, Juliano, Dr. Francisco, e a nossa primeira centena de assistentes, né, para hoje. Então, fico muito feliz de estar podendo participar dessa atividade, parabenizar o João Lindorff e toda a diretoria por todas essas atividades que têm sido realmente um sucesso, mas, sobretudo, cumprimentá-los pelo recorde, né, de público diante de tantas atividades que a gente tem atualmente via online, né, e a gente ter um a nossa regional tão ativa. Então, muito obrigado pela oportunidade. E eu quero aqui de público, né? Estava aguardando aqui de público para agradecer ao Dr. Mike pela conferência belíssima, prática que ele deu aqui no nosso SBEM online. Então, ele já veio uma vez presencialmente em Brasília, em 2019. Essa é a segunda vez que ele vem à distância, né? E eu espero que no próximo ano, né, João, você já adiantou aí, que ele possa vir para empatar o jogo, né? De 2-2, tá bom? Então, boa noite a todos. Eu chamo o colega Dr. Francisco para que ele possa apresentar o nosso palestrante. Então, um bom evento a todos. Muito obrigado.
Boa noite a todos. Inicialmente, eu gostaria de agradecer o honroso convite ao professor João Lindolfo. É um prazer fazer parte dessa mesa, um tão ilustre convidado, e ao Newton também. Obrigado por estar dividindo comigo essa mesa, Newton. E é um prazer fazer a introdução do professor Levick, que tem uma grande contribuição no campo do metabolismo ósseo. Ele é diretor de pesquisa clínica do Novo México e diretor de saúde óssea no Centro de Osteoporose da Universidade do Novo México. O Dr. Levick publicou cerca de 300 papers, né? Então, ele realmente tem uma produção científica muito significativa e sua contribuição realmente é uma das maiores dentro da nossa área. É um prazer ouvir essa noite mais uma vez, Dr. Mike.
Thank you very much for inviting me to do this, and I will share my slides here. So I'm going to talk to you today about what's happened in the past year with vitamin D. And before I start, though, I'd like to pay my respects to my dear friend, Linda Marr, who we lost earlier this year. He was a fine gentleman, a good friend, a wonderful expert in osteoporosis. And I very much enjoyed all the times that I got together with Linda Marr on my many trips to Brazil, at meetings and in social occasions, and seeing Linda Marr at meetings in the US and at other places around the world. He's a fine man, a great loss to me and to many of you listening, I think, personally. And I'd just like to express my deepest condolences to Linda Marr's family at his loss. This is my disclosure. And I have no direct compensation from any conflicting entities and nothing with regard to vitamin D. The objectives today are to identify selected publications on vitamin D in the past year, describe the role of vitamin D in the regulation of inflammation and immunity, and consider potential new therapeutic applications for vitamin D. And of course, the big news for vitamin D in the past year has to do with COVID. And just to find out a little bit more how much interest there was in vitamin D in COVID, I did a PubMed search matching vitamin D and COVID, and I got 588 publications that came up on PubMed. To see how much general interest there was, I went to Google and I Googled vitamin D and COVID-19, and I got many, many millions of matches. So it's very clear that there's a great deal of interest worldwide in COVID and vitamin D. Now, I think you're all very familiar with the classical endocrine functions of vitamin D. We know that vitamin D regulates calcium and phosphate homeostasis, involving bone, gut, and kidneys in coordination with actions of PTH and FGF23. Low vitamin D increases bone turnover, reduces bone density, and increases fracture risk. But there are also non-classical target tissues for vitamin D that get much less attention. We know that skin is a target tissue and that vitamin D has an anti-inflammatory effect. It inhibits keratinocyte proliferation, and its vitamin D analogs are used as a treatment for psoriasis for this reason. There are also effects in the pancreas. There are vitamin D receptors in pancreatic beta cells, and 1,25-dihydroxyvitamin D is known to stimulate insulin secretion, although the mechanism of this is not entirely clear. And in immune cells, vitamin D modulates both innate and adaptive immunity in a fashion that upregulates innate immunity and downregulates adaptive immunity. And this is what's gotten a lot of attention with regard to vitamin D and COVID-19 infections. And here, of course, looking at the classical effects of vitamin D deficiency, we know that it causes rickets in children and osteomalacia in adults. On the right-hand image, you see a Loesser's line. This is a pseudo fracture that's due to vitamin D deficiency. And this is quite different than atypical femur fractures, which cause focal cortical thickening and radiolucency if there's a partial fracture, which is in the lateral cortex. And classically with vitamin D deficiency, it's in the medial cortex of long bones. Now, we know that observational studies have shown associations between low vitamin D status and many, many disorders, as you see listed here, including associations between vitamin D status and COVID-19 infections and mortality. However, as everybody knows very well, associations are not the same as causality. Now, this is some of what we know about vitamin D and innate immunity. Innate immunity is the first line of defense against bacteria, viruses, and cancers. This is activated within hours of exposure to a pathogen.
É o negócio lá internacional.
Sabe o que tinha que fazer na minha tarefa?
Okay, we got some background noise here. We know that when monocytes are exposed to pathogens, there's upregulation of CYP27B or 1-alpha hydroxylase and vitamin D receptors. And this increases 1,25-dihydroxy D3 levels at the site of infection. And these high levels, in turn, serve to activate production of peptides that enhance the antimicrobial effects of monocytes and macrophages. Low vitamin D levels are associated with infections such as tuberculosis, upper respiratory tract infections, urinary tract infections, HIV infection, and sepsis. And some studies suggest that treatment with vitamin D may reduce the risk of some infection. And we know with tuberculosis, for example, that for many years before we had antibiotic treatments for tuberculosis, patients would get therapy in the sun, and they would go to sunny places and get exposed to the sun and presumably increase their vitamin D levels, and hopefully the infection would improve. Now, adaptive immunity is the second line of defense, and this is activated over days and weeks. It's mediated by B cells and T cells with immunological memory. And it's also responsible in some cases for autoimmune reactions. Vitamin D serves to suppress adaptive immunity, and we've seen this in vitro and in animal studies that show downregulation of immune responses of T helper 1 cells and reduced levels of inflammatory cytokines, although the data in humans are inconsistent. Low vitamin D levels are associated with autoimmune and chronic inflammatory diseases such as rheumatoid arthritis, coronary artery disease, type 1 diabetes, Hashimoto's, and Graves' disease. But there is no convincing evidence that vitamin D is effective in treating these diseases. Now, this publication a long time ago in 2009 actually got a lot of attention. This was from the U.S. National Health and Nutrition Examination Survey, showing that regardless of the season, patients with higher vitamin D levels had fewer upper respiratory infections. And it was stated here that the emerging role of vitamin D in innate immunity provides a plausible mechanism for the association of serum 25-hydroxy-D levels and upper respiratory infections. And it was said that randomized controlled trials are warranted. So subsequent to that, there were many randomized controlled trials, as you see here in a meta-analysis of these trials. And the meta-analysis concluded that vitamin D supplementation reduced the risk of upper respiratory infections. The protective effects of vitamin D were seen in patients receiving daily or weekly doses, but not those with large doses given infrequently. The protective effects were the greatest in patients with very low baseline levels, for example, less than 10 nanogram per milliliter, but were also seen in patients with higher baseline levels. So this got a lot more attention focused on the relationship between vitamin D and infections. And when COVID-19 came along, the question arose, if vitamin D reduces the risk of URIs by enhancing innate immunity, could vitamin D supplementation reduce the risk of acquiring a COVID-19 infection? And if vitamin D suppresses adaptive immunity in humans, could vitamin D supplementation reduce the risk of cytokine storm that appears to be responsible for the acute respiratory distress syndrome and death that's seen in some patients with severe COVID-19 infections? Now, John Bilezikian and colleagues published this paper in the past year about the mechanisms of vitamin D as a regulator of innate immunity. And you can see in the diagram at the left, possible macrophage responses to viral infections. And it was stated here that the innate immune response includes induction of autophagy in macrophages by vitamin D, with autophagy being the encapsulation of viral particles for lysosomal degradation, subsequent antigen presentation, and activation of adaptive antiviral responses. And it's thought that as free 25-hydroxy vitamin D enters the cell, it's converted to 1,25-dihydroxy-D, which binds to vitamin D receptors and induces a number of regulators that serve to promote autophagy. So perhaps this is how vitamin D works. Of course, not all of this is completely confirmed, but it's certainly a plausible mechanism. Here's another study from the past year entitled Exploring Links Between Vitamin D Deficiency and COVID-19. And here it's stated that vitamin D downregulates adaptive immunity by reducing T cell proliferation, reducing T helper type 1 proliferation, reducing pro-inflammatory cytokines, and increasing anti-inflammatory cytokines. So this, again, is a plausible mechanism to explain the effects that vitamin D might have on at least some infections. So here is a retrospective study. This got a lot of attention when it came out. This was in April last year. 212 cases of COVID-19 infections in 3 hospitals in Southern Asian countries. And it was found that vitamin D levels were significantly associated with clinical outcomes with a highly significant p-value. And the better the vitamin D level, the better the outcome, as you see in those sub-bullets. And they concluded that the odds of having a mild versus a critical outcome with infection were increased 19-fold for every standard deviation increase in serum 25-hydroxy vitamin D. So this led a lot of people to start taking more and more doses of vitamin D to help prevent COVID. Here's a study out of Europe showing a relationship in various European countries between the mean vitamin D levels in those countries and rates of infection and mortality related to COVID. And what you see here is, again, an association in these observational studies between higher doses of vitamin D and milder outcomes and fewer infections with COVID. So looking at Brazil, the question was asked, does vitamin D play a role in the management of COVID-19 in Sao Paulo? So this study found that 72% of institutionalized older adults and about 44% of older people attending outpatient clinics showed lower levels of vitamin D3 than recommended, and that adequate vitamin D status may play a role in prevention and management of respiratory tract infections, which might include COVID-19, especially in older populations. And it was recommended that ecological, epidemiological, and randomized controlled trials be conducted to verify this hypothesis. So that was done. And here is the publication that came out in JAMA earlier this year, looking at the effect of a single high dose of vitamin D3 on hospital length of stay in patients with moderate to severe COVID. And this study was conducted in 2 hospitals in Sao Paulo. And as you can see on the graphs, the lines are almost superimposed with those patients getting vitamin D and those patients getting placebo. There were 240 patients hospitalized in this study. They were randomized 1-to-1 to receive vitamin D3 200,000 IU by mouth or placebo. And there was no difference in hospital length of stay, mortality, or the need for mechanical ventilation. So no evidence in this randomized controlled trial that there was benefit of supplementation with vitamin D and outcomes. So this same topic was reviewed in a note that was published online in Brazil, saying that there are no indications for vitamin D supplementation other than for bone health, and also that there's no proven benefit of vitamin D supplementation for prevention or treatment of COVID-19 infections. ASBMR also published online a joint guidance on vitamin D in cooperation with a number of organizations, as you see here. And they stated that observational studies have shown associations, as I previously outlined, but that there's no evidence that vitamin D supplementation can prevent or treat COVID-19 infections. They stated that sunlight exposure is an excellent source of vitamin D, and that vitamin D supplements 400 to 1,000 IU per day may be useful for those having less sunlight exposure, and that vitamin D is very safe when taken at reasonable doses. Now, Renee Rizzoli published a very nice review and overview of vitamin D from a safety standpoint early this year. So he talked about the potential harms of excess vitamin D supplementation. And he noted that the usual presentation of patients with vitamin D toxicity is hypercalcemia, hypercalciuria, and soft tissue calcifications. But he noted that there may be other manifestations related to bone health, as well as falls, frailty, kidney stones, and increased mortality. And he reviewed some of the previous publications in this area. In the portion about bone health, Renee noted a study that showed an increased risk of hip fracture with vitamin D2 doses of 300,000 IUs given IM once a year for 3 years compared with placebo, and an increased risk of fractures with a single dose of D3, 500,000 international units by mouth compared with placebo. Looking at falls as an adverse outcome, there was a study published that showed an increased risk of falls with a single dose of D3, 500,000 IUs by mouth compared with placebo. And he concluded that vitamin D 800 to 1,000 IUs per day, or calcifediol, which is used primarily in patients with chronic kidney disease in the US, in a dose of 10 microgram per day is safe. And he stated that large intermittent doses of vitamin D should be avoided. The big news in vitamin D circles in the past year had to do with the VITAL study. And in the Journal of Clinical Endocrinology and Metabolism, this study was published. VITAL is a double-blind, placebo-controlled, randomized controlled trial with over 25,000 generally healthy men and women in the US, age 55 years and older, who were randomized to receive vitamin D3, 2,000 IUs per day, or placebo. Note that the baseline vitamin D level in this population was 31 nanogram per milliliter, which was quite good. The conclusion in this report is that there was no difference in falls with D3 2,000 IUs per day. And the graph on the upper left shows 2 or more falls. At the bottom left, it shows falls requiring hospitalization, and no difference at all between vitamin D and placebo. Another publication from the VITAL trial looked at bone health outcomes. This was an ancillary study in a subcohort of over 700 participants who had a baseline DEXA and follow-up at 2 years. In this cohort, the baseline vitamin D level was 28 nanogram per milliliter. And as you can see in the chart on the left, there was no difference in BMD at 2 years with D3, 2,000 IUs per day. So what can we conclude from these publications? I have to go back to my guru for vitamin D, Dr. Robert Haney from Creighton University in the US. And he reminded us in this publication in New England Journal that vitamin D is a threshold nutrient. And you see that expressed in the graph on the left. And if I could channel Dr. Haney and imagine what he would say, this is what he would say, I think. The problem with VITAL and with most nutritional studies is that giving more of a nutrient to someone who already has enough and not giving enough to reach the steep portion of the response curve that you see on the left, we're unlikely to see a treatment effect. An adequately designed study should consider the baseline level of the nutrient and the dose that is given. And many studies, including the VITAL study, I think, fail on one or both of these. So I think in the VITAL study, we have subjects who were already had an adequate level of vitamin D, and giving more vitamin D to those patients could not be expected to provide any additional effect. Here, I think, is a final set of words published by Paul Lips and colleagues in JBMR Plus over the past year. The title is nice, I think. Vitamin D giveth to those who needeth. And they said again that vitamin D is a threshold nutrient, that patients who are deficient should be supplemented. Giving more to someone who already has enough is not helpful. Most studies of vitamin D supplementation show no effect because the subjects were already sufficient. And vitamin D is an essential nutrient, but it's certainly not a cure for all diseases. Now, ACE had a guideline update in the past year, and they suggested the following: to measure serum 25-hydroxy vitamin D, not 125 dihydroxy vitamin D, in patients who are at risk for vitamin D insufficiency, particularly those with osteoporosis, and to maintain the serum 25-hydroxy D level above or equal to 30 nanogram per milliliter in patients with osteoporosis. And they suggested we supplement with vitamin D3 if needed, with a daily dose of 1,000 to 2,000 IUs, and that higher doses of vitamin D may be necessary in some patients. For example, those with obesity, malabsorption, and older age. We're seeing many more patients, for example, with bariatric surgery who have malabsorption problems, and it's a challenge sometimes maintaining an adequate vitamin D level. There are some unforeseen skeletal consequences of COVID-19. And we've discussed these on Bone Health Tele-Echo over the past year. And one of them is that vitamin D toxicity has been seen by our participants due to excessive vitamin D supplementation, hoping to prevent COVID infections. Other unforeseen consequences that have been reported are more stress fractures due to patients exercising more because they're homebound and they're out walking or hiking more. More falling because of impaired fitness and balance due to shutdown of exercise facilities and physical therapy places. And I had a patient who had a fracture. I'm calling it a COVID fracture. She was mountain biking, and she was on a narrow rocky trail. She took one hand off the handlebars to adjust her mask when someone else came along the trail, and she crashed her bike and had a fracture as a result. So to summarize, vitamin D, preclinical studies show that vitamin D enhances innate immunity and suppresses adaptive immunity. There's no evidence that vitamin D supplementation is effective in preventing or treating COVID-19 infections. Since vitamin D deficiency is common and vitamin D supplementation is very safe, attainment of vitamin D adequacy is desirable, certainly at least more than 20 nanogram per milliliter, probably better to be over 30. There's no known benefit in giving more vitamin D to someone who already has enough, and high doses of vitamin D given intermittently may increase the risk of falls and fractures. And now I'd just like to close by saying a few words about Project ECHO. This is about sharing knowledge through ongoing video conferences. So what we're doing today is a video conference, but ECHO is a regular recurring event that typically happens once a week or once a month. And it's focusing on interactive case-based learning with the idea of expanding capacity to deliver best practice medical care in underserved communities at lower cost and greater convenience than referral to a specialty center. And this is sometimes called a hub and spoke system of learning. This gives you an example of what we have in the US. We have a hub at University of New Mexico in Albuquerque, and we reach out to participants in many parts of the United States, as you see here. And other ECHO programs have started up in other places around the US, as you see listed, mostly on the East Coast and the Midwest, with another one starting up on the West Coast in a few weeks. We also have participants in many other countries from time to time. We have Canada, Mexico, and South America on a regular basis. We have had participants in Chile and Brazil, and it's always been a great pleasure to have that level of involvement. Now, I'd just like to suggest to you that this ECHO model of video conferencing might have some applications in Brazil and in cooperation with other organizations, for example, and potential ECHO applications in the field of endocrinology might be programs focused on osteoporosis or diabetes, rare bone diseases, DEXA, or for fellows in programs at institutions that lack local expertise in some of these diseases. And in fact, there are already some Project ECHO programs that are ongoing in Brazil, as you see here on the left. So Project ECHO is already established in Brazil, and doing more of it might be of interest to some of you. And this is my final slide. This is the Albuquerque International Balloon Fiesta. This is held every year in the fall. It was canceled last year, but I'm told it's going to happen again this year when we have many hundreds of balloons from around the world. Usually we have some from Brazil as well. It's great fun. I live close to the area where these balloons take off, and they frequently fly over my house. We get to wave at people in the balloons, and sometimes they land in the field behind our house. So thank you for your attention, and I welcome any comments or questions.
Ok, eu gostaria de agradecer a palestra bastante interessante e dividir os seus pensamentos sobre vitamina D e a resposta imune, Dr. Lewick. Eu queria lhe fazer uma pergunta.
You're welcome.
É a questão, quem dos metabólitos da vitamina D alcança os outros tecidos e células? Seria o colecalciferol, o 25-hidroxi ligado à proteína ou o próprio calcitriol? Se essas células do sistema imune têm sistema de transporte, cubilina, megalina, ou se eles utilizam toda a maquinaria para sintetizar localmente a vitamina D?
Well, I think we see a lot of all of that. We see 1,25-dihydroxy vitamin D3 formed in the kidneys and circulating in the blood. We also see 25-hydroxy vitamin D3, most of which is bound to vitamin D binding protein. And this gets transported across the cell membrane of many cells and many tissues, and is converted in these peripheral cells to 1,25-dihydroxy D. And that is largely responsible for the peripheral effects that and the paracrine effects that's seen with vitamin D. So it's a complicated arrangement with many metabolites, some of which are protein bound, and intracellular effects of cascading effects of vitamin D. And there's a great deal more we need to learn about it. I think the effects of vitamin D in the pancreas, for example, in stimulating insulin secretion are really interesting. But there's a lot we need to understand about exactly how that works from a mechanism standpoint.
Na sua opinião, o esquema de frequência semanal seria razoável ou melhor diário o uso da vitamina D?
Well, I think there's hundreds of different ways to supplement vitamin D. My personal preference is to do it daily with vitamin D3. What I've seen frequently in my practice is that patients with vitamin D deficiency have been started on large doses of weekly vitamin D. So, for example, they might be given a prescription of vitamin D, 50,000 international units, and told to take that once a week for 2 or 3 months. And what I've found is that it often happens that patients will do that for 2 or 3 months, then they'll finish their prescription and they won't take anything else afterwards. And they come back a year later and they're vitamin D deficient again. So I use the Bob Haney technique, and this is what Dr. Haney proposed many years ago, that we begin with over-the-counter vitamin D3, which is inexpensive and easily available. And a nice way to do that in a vitamin D deficiency patient is to begin with a larger dose than maintenance. So if I have a patient with vitamin D deficiency and say the level is 15 nanogram per milliliter, I might tell them to get over-the-counter vitamin D3, 2,000 international units, and take 5 a day or 10,000 international units for 2 weeks. And then to go down to taking 1 a day, 2,000 international units a day, and to maintain that indefinitely, forever. And then I'll measure a vitamin D level again 3 or 4 months after doing that. And usually I'll find that it's in that range between 30 and 50 nanogram per milliliter. So that's an easy way to do it. And that way the patient understands from the beginning the importance of maintaining vitamin D supplementation lifelong, and not just stopping it after taking a high dose for several months.
E o João Lidolfo está com a mão levantada.
Eu estou aqui como palestrante, então não tenho espaço para fazer pergunta. Mike, primeiramente, parabéns pela sua aula, fantástica, como sempre, muita coisa nova desde o ano passado, e eu queria dizer que a família do Dr. Lindomar, a quem você prestou homenagem, está presente aqui hoje e eles pediram para agradecer as suas palavras. Então, eles estão muito felizes comigo. Muito obrigado.
Thank you very much. Thank you.
Existem algumas perguntas aqui, estão sendo feitas no chat, mas as perguntas devem ser feitas no ícone, question and answer, na parte inferior direita, para que doutores Francisco José e Tonilton possam escolher. Obrigado.
De qualquer forma, tem uma que está perguntando se existe alguma indicação para a vitamina injetável, na sua opinião.
I think there are indications for injectable vitamin D. Unfortunately, we do not have it in the US. There is no approved injectable form. But I think there are patients with severe malabsorption problems and some patients who can't tolerate oral preparations who might be good candidates for injectable therapy. In patients with extensive bowel surgery, a short gut syndrome, some patients with bariatric surgery can have severe malabsorption problems. And we've had some of these patients where we have to give massive doses of oral therapy, and sometimes we still can't get the vitamin D level up high enough. And these are cases where I have told people to go to tanning salons and get exposed to UVB rays. I've told them to go out in the sun without sunscreen. which we don't normally do. And sometimes that helps, but it would be very appropriate, I think, to give injectable vitamin D in these patients if you have it available. And I wish we had it in the US.
Mike, você pensa que toda gestante e todo recém-nascido deve receber vitamina D?
I don't normally deal with that, but yes, as far as I know, that's a standard recommendation, at least here in the US, for pregnant women to take prenatal vitamins that include vitamin D. You certainly don't want a pregnant woman to be vitamin D deficient. There are pregnant women who have gotten fractures during pregnancy or during childbirth, and especially after childbirth during lactation. That's a time when there's very commonly some significant bone loss. And if there are fractures associated with pregnancy, they're most likely to occur during the time that the mother is breastfeeding. So I think vitamin D supplementation during pregnancy and during the time of breastfeeding is very appropriate.
Eu acho que aqui, João, não tem nenhuma pergunta no...
Mas eu gostaria, então, que o Dr. Mike comentasse. A gente falou sobre essa questão das altas doses. Aqui no Brasil, nós tivemos uma onda de pessoas querendo prescrever doses muito elevadas. Se o senhor pode fazer algum comentário sobre as complicações dessas superdoses.
Well, it does seem that extremely high doses of vitamin D can increase the risk of falling and possibly increase the risk of fractures even independently of falling. And with vitamin D levels that get very high, if they're up over 150 nanogram per milliliter, there's certainly a risk of vitamin D toxicity with hypercalcemia, nephrocalcinosis, and kidney stones, and ectopic calcification. So all of those things might occur. Now, there have been some interesting studies done. Neil Binkley and colleagues studied vitamin D levels in Hawaii in skateboarders and surfers who spent most of their time exposed to the sun, many of them without sunscreen. And he wanted to see what their vitamin D levels were. And some of them had low vitamin D levels, surprisingly, but almost none of them had higher levels than 80 nanogram per milliliter. And it's also been studied in African farmers who spend a lot of time in the sun, not wearing a shirt. And again, the highest levels were around 80 nanogram per milliliter. So that leads us to believe that that's the physiological upper limit of normal, and that it may be pathological to give so much vitamin D that you're getting levels up above 80 nanogram per milliliter. And the studies have indeed shown that there's possible harm with doing that. So as my father always told me, moderation in all things is good. My father lived to be 97, and I hope I do as well as he did. And I have not always listened to him. I've not always been moderate like I should be, but I'm beginning to realize that he may have been onto something when he suggested moderation.
Mike, você já teve a oportunidade de ver algum paciente com deficiência de 24-hidroxilase e desenvolver hipercalcemia durante o tratamento com vitamina D?
I have not seen such a patient. I've looked for those patients, but I've not had any myself.
Mais uma pergunta aqui. A doutora Bárbara Campolina é uma colega nossa que é estudiosa também do metabolismo ósseo. E ela, primeiro, cumprimento pela ótima aula, e ela gostaria de saber qual o mecanismo que explicaria quedas e fraturas após doses altas de vitamina D dadas em bolos.
That is an excellent question, and I don't know the answer. You know, there are vitamin D receptors on muscle cells, and it's been thought that overexposing those receptors to vitamin D might have adverse effects on contractility or even balance, but the exact mechanism is unknown to me. And I think it'd be very interesting to explore that and find out a little bit better what might be doing it. And it's a good opportunity probably for animal studies. So if anybody needs a research project, or if you have some fellows in the laboratory somewhere who could do that, that would be an excellent study.
Se eu posso acrescentar ali na questão de quedas, existe uma teoria que com a hipercalcemia pelas doses altas de vitamina D, você tem desidratação e com isso aumenta as chances de quedas.
I don't know. That's a good hypothesis, and that could be explored further too.
Aqui tem uma pergunta da Luciana Lobato. Na sua opinião, qual é a frequência que crianças e adolescentes com diagnóstico de AIDS devem receber vitamina D? E qual a frequência que a dosagem de vitamina D deve ser feita?
Well, I would say for children and adolescents with AIDS, there are often nutritional concerns, and I think it's appropriate to have a vitamin D level in the same range that we recommend for others, and that 30 to 50 nanogram per milliliter range. And I think it would be appropriate if there are any nutritional concerns at all to measure a vitamin D level early on. If it's low, to give them supplementation. I usually repeat a level about 3 months after starting the supplements. And if it's up in the range that I'd like to achieve, I might repeat it once a year after that, but I think that's probably often enough unless there's been a major change in the patient's health status.
Mike, você tem experiência com esclerose múltipla e vitamina D? Aqui no Brasil tem uma pessoa que trabalha com vitamina D e dá doses altíssimas de vitamina D para pacientes com esclerose múltipla. Você tem experiência com isso?
Well, I have patients like that who are given very high doses of vitamin D by their neurologist. And the same with cancer patients. We have oncologists who are telling their patients to take very high doses of vitamin D. In fact, I saw somebody today who's taking high doses from their oncologist, much higher than I would be recommending. And I think they're doing this on the basis, as far as I know, of observational studies that show an association between higher vitamin D levels and having fewer problems with multiple sclerosis or cancer. I don't think there's any well-established causal relationship, but I know this is very popular to do. And when I see patients with multiple sclerosis or cancer who are getting high doses, and I check their vitamin D level, I don't want to have an argument with the neurologist or the oncologist. go along with what they say, as long as the levels don't get extremely high. I have had patients getting levels up to close to 150 nanogram per milliliter, and I'll tell them to back off at that point because they're in danger of having some serious complications. But if they're merely getting their levels up to 80 or 90, I'm okay with that. I think that's probably not harmful, and if it makes the oncologist and the neurologist happy and the patient's happy, then I'm happy too.
Ok. Ok, João, eu acho que nós não temos nem mais nenhuma pergunta.
Tem mais pergunta, tem uma pergunta ainda.
Tem uma pergunta?
Tem aqui da Lohana, para pacientes que alto risco para Covid, qual seria a dose diária recomendada? Doses como 1.000 ou 2.000 unidades?
Well, my thought is that vitamin D is probably a marker for good health and good nutrition. So, healthy people who often take vitamin supplements have a good vitamin D level. And those are the people who are likely to do better if they get a COVID infection. I'll tell you what I do. I take 2,000 IUs of vitamin D3 every day. And my vitamin D level, the last time I checked it just for fun, was 36 nanogram per milliliter. So I'm happy. I don't feel a need to get it any higher. I think 2,000 IUs a day is very safe. It's inexpensive and easy to take. So if you want to be sure that a patient has an adequate D level, that might be fine. And probably 1,000 IUs a day would do the job for most people as well. So those are my thoughts. The rest of you can vote on how much vitamin D you take, and we'll see how we match up.
I like the sunshine. Só de curiosidade, no começo desse ano eu fiz uma pequena aula, até lhe consultei algumas coisas sobre medicações de osteoporose durante a pandemia. Em geral, as medicações para osteoporose no Brasil venderam menos, as pessoas estão indo menos ao médico de uma maneira geral, não estão repondo suas receitas, mas para a vitamina D não aconteceu. Um dos fabricantes me disse que eles vendiam, em geral, 250 milhões de reais ao ano. Durante a pandemia foi 1 bilhão de reais ao ano, ou seja, 4 vezes mais automedicação, ou medicação desses loucos por aí.
Mais uma coisa, né, João? Gostei de ver. Assim,
I'm not surprised. Yeah, it's probably the same in the U.S. I bet it's gone way up. Yeah.
Eu gostei de ouvir a posição bastante equilibrada do Dr. Mike, que coincide com o que eu penso também a respeito do tema.
Mike, então, agradeço a você, agradeço a todos presentes, agradeço a Xê, que nos deu um suporte muito grande, mais uma vez, fantástico. Quem sabe para o ano que vem, para o Endo Centro-Oeste, a gente te vê ao vivo aqui em Brasília. Muito obrigado, obrigado mesmo. Obrigado à família do Lindomar, que está aqui presente. Obrigado ao Newton, ao Franzé. Muito obrigado a todos os participantes que estão aqui presentes à noite. Boa noite para todos.
Um abraço.
Thank you for having me.